We will start with the next topic for today, posterior abdominal wall. The posterior wall of the thorax and abdomen has got a deep fascia which is called as thoracolumbar fascia. Thoracolumbar fascia, when it approaches the midline posteriorly, splits into three laminae. The middle laminae gets attached to the tip of the transverse process of the lumbar vertebrae. The structure in front of the middle laminae is called as posterior abdominal wall. The structure posterior to the middle laminae is called as back. So don't equate posterior abdominal wall and back. So what is lying between the middle lamina and anterior lamina of thoracolumbar fascia is posterior abdominal wall. So here we are seeing the posterior abdominal wall. What you can see, vertebral column, the lumbar vertebrae, just close next to it is a large psoas major muscle. In some individuals, there is also a muscle which is anterior to psoas major, that is called as a psoas minor muscle. Structure lateral to the psoas major in relation to the lumbar vertebrae and iliac crest, above the iliac crest, is quadratus lumborum. You can see the thoracolumbar fascia middle lamina, which is passing behind the quadratus lumborum, making quadratus lumborum a muscle of the posterior abdominal wall. Below the iliac crest, lateral to psoas major, is the iliacus muscle. The diaphragm forms the superior wall, and the pelvic diaphragm forms the inferior wall. Besides psoas minor muscle, which is a vestigial muscle, other vestigial muscles in the body are palmaris longus, palmaris brevis, both muscles of the upper limb. Plantaris, equivalent to palmaris longus in the lower limb. Pyramidalis, this is the muscle of the anterior abdominal wall, which we did not describe when we discussed the anterior abdominal wall. Is the pyramidalis which lies in front of rectus abdominis. This is the equivalent of kangaroo's pouch. So obviously, since we are not kangaroos, this muscle is poorly developed. And the platysma. Platysma, we will say, is an important muscle of the neck. But then, remember, in lower animal, the entire skin, within the skin, is a fleshy muscle called as panniculus carnosus. Platysma is a vestigial remnant of panniculus carnosus present in the neck. So 6 muscles in the body which are vestigial, all of which start with the letter P. In the posterior abdominal wall, what you are seeing is the psoas major has been cut on the right hand side and it's intact on the left. What you are seeing exactly in the midline is the abdominal aorta. Abdominal aorta bifurcates at L4 vertebral level. This abdominal aorta divides into 2 common iliacs. The common iliacs divide into external iliac, which then continues as femoral, and an internal iliac which supplies the pelvis. Now, internal iliac artery is an important artery for the gynecologists because they are essentially focusing on the pelvis, and the artery of the pelvis is the internal iliac artery. And the hemorrhage from the uterus There are multiple ways by which you can stop, but the ultimate solution, if there is uncontrolled hemorrhage from the uterus, is to ligate the internal iliac artery. So the branches of internal iliac and the subsequent continuation of internal iliac, etc., all has to be managed by the gynecologist. So in the PG gynac PG exams, they usually ask last question as the branches of internal iliac artery. There was one good student who answered excellently all the branches of the internal iliac artery. Then the examiner did not want to give up. So then he said, tell me the branches of abdominal aorta. And this student immediately answered, there is one abdominal aorta which divides into two terminal branches, the common iliac arteries, which gives rise to three ventral branches at the vertebral level of T12 is the celiac trunk. At the L1 vertebral level is superior mesenteric artery, and at L3 vertebral level is inferior mesenteric artery. Three ventral branches. The celiac trunk is for the foregut structures in the abdomen. The superior mesenteric artery is for the midgut structures, and the inferior mesenteric artery is for the hindgut structures. Celiac trunk is called celiac trunk because it immediately divides into its three branches. Any artery which has got the diameter which is greater than the length is called a trunk. So celiac artery is a trunk because it immediately divides into what you can see here. A very short cut left gastric artery, the splenic artery going to the left, and the hepatic artery going to the right. So three immediate branches. Other trunks in the body are pulmonary trunk arising from right ventricle. Then from the arch of aorta, the first branch of arch of aorta, brachiocephalic trunk, and subclavian artery gives rise to two trunks, the thyrocervical trunk and the costocervical. So five arteries have got trunks: celiac trunk, pulmonary trunk, brachiocephalic trunk, thyrocervical trunk, and costocervical trunk. Foregut structures in the abdomen would be stomach, duodenum up to and including the second part of duodenum up to major duodenal papillae, liver, gallbladder, pancreas. Superior mesenteric would mean duodenum beyond the opening of major duodenal papillae, the bile pancreatic duct. Beyond that, and then into jejunum, ileum, cecum, appendix, ascending colon, and the right 2/3 of clavicle. And beyond that is the section hindgut, which is supplied by the inferior mesenteric artery. There are four lateral branches of the abdominal aorta. In the uppermost part is the one which is going and supplying the diaphragm, inferior phrenic artery. Incidentally, inferior phrenic artery will also give branches on the way as a superior suprarenal artery. This is a suprarenal. The second branch laterally is a direct branch to suprarenal from the abdominal aorta. That is called as middle suprarenal artery. The third lateral branch is the renal artery, which supplies the kidney. But just before it supplies the kidney, it gives a branch to the suprarenal, inferior suprarenal artery. So suprarenal artery is supplied by three branches. Superior suprarenal, a branch of inferior phrenic. Middle suprarenal, direct branch of aorta. And inferior suprarenal is a branch from the renal artery. All these three arteries form anastomose in the capsule of the suprarenal. Then it sends radiating branches into the suprarenal. Suprarenal is drained by a single vein, which will join directly or indirectly to the inferior vena cava. So inferior phrenic, middle suprarenal, renal, and then another artery is called as a gonadal artery. So 4 lateral branches, 5 dorsolateral or somatic branches. Lateral branch, which is called dorsolateral branch, number 1, number 2, number 3, and number 4. 4 lumbar arteries are given by the abdominal aorta. The 5th lumbar artery is not given by abdominal aorta. So one would wonder why there are 5 lumbar vertebrae. There should have been 5 lumbar arteries, but only 4 lumbar arteries are given by the abdominal aorta on each side. That is because abdominal aorta bifurcates at L4. So it can't give the 5th lumbar artery. Instead, the 5th artery, which was the embryological continuation of abdominal aorta, the thin median sacral artery, median was in the midline. This was the original continuation of abdominal aorta, but now it being so small, we are considering the abdominal aorta terminates by giving 2 common iliacs, and at that point, a dorsolateral running vessel, the median sacral, is the 5th somatic branch. 5 somatic branches are 4 paired lumbars and the 5th median sacral. So that is the branches of abdominal aorta. 1 aorta, 2 terminal branches, 3 ventral branches, 4 lateral branches, and 5 somatic branches. Internal iliac, as we said, immediately divided into an anterior division and a posterior division as soon as it enters the pelvis. Anterior division gives visceral branches, which will supply the organs of the pelvis, the urinary bladder, which will be superior and inferior vesicle. Inferior vesicle essentially supplies the prostate. Obviously, prostate is absent in females, so inferior vesicle is also absent in females. Instead, there is an artery which is called as vaginal artery. There is an additional branch in the females which is called as uterine artery. Obviously, there is no equivalent of this artery in males. Uterine artery is a helicine artery. That means the tunica media of the uterine artery does not run circularly, it runs elliptically in a spiral manner. That's why spiral is called helix, the artery is called helicine. The reason for this is that uterus, which is normally a pelvic organ, can rise all the way up to the diaphragm in pregnancy. So the uterine artery has to compensate for that extra and large growing abdomen. This is possible only if the artery is helicine, so that we can stretch the artery without compromising the blood supply. Otherwise, if you stretch any artery, the diameter will keep on decreasing. Here it does not, because the artery be helicine. And of course, there is a branch going to the rectum, which is rectal artery. So anteriorly, there is a superior vesicle and inferior vesicle in males replaced by vagina, a separate artery for uterus, uterine artery, and behind that is an artery to the rectum, the middle rectal artery. Remember, rectum is a part of hindgut. So hindgut artery is the inferior mesenteric, and inferior mesenteric gives only superior rectum. The middle and inferior recti are left to the internal iliac giving branches. And then, of course, it has got somatic branches. One artery which is going into the lower limb from the anterior division of internal iliac is the obturator artery. Obturator artery accompanies the obturator nerve into the obturator foramen and enters the thigh. The obturator nerve supplies the adductor muscles. The obturator artery is too small. So obturator artery is described as a failure. It is too small to supply the medial huge muscles, adductor longus, brevis, pectoris, gracilis. So adductor obturator artery enters the thigh, suddenly is taken aback by the huge sized adductor muscles. So it hides, escapes, and goes into the hip joint and then accompanies the ligamentum teres of the head of the femur and then supplies the head of the femur in a child. As the child grows up and the head and the neck get fused, after the growth of the child, the obturator artery is too small to supply even the head of the femur. So it is left supplying only the ligament of the head of the femur. In addition to that, there are two more branches which go laterally, which are somatic branches of anterior division of the iliac. One is the internal pudendal artery, which will supply the perineal organs, which we'll discuss in a subsequent class, and inferior gluteal artery, which is the original axis artery of the lower limb. Femoral has developed later. Femoral artery is larger, but internal iliac artery is the original axis artery. It's a femoral artery which gives rise to profunda femoris. And profunda femoris gives a medial circumflex femoral which supplies the head. Posterior division of internal iliac will give rise to iliolumbar. You can see here going along the iliac crest is the iliolumbar artery. This is the fifth lumbar artery. We said that the somatic branches, abdominal aorta gives only 4 lumbar branches. The fifth lumbar artery is called iliolumbar artery. Lateral sacral artery. You can see it in the midline, the median sacral artery, and you can see vessels anastomosing from the lateral side. They are called as the lateral sacral artery. So remember, lateral sacral artery is coming towards the median midline, and iliolumbar goes away from the midline. And of course, the largest branch of the internal iliac artery is a continuation of the posterior division of internal iliac artery, which is called as superior gluteal artery. Inferior gluteal is a branch of anterior division. Superior gluteal is a branch of posterior division. Inferior gluteal, we said, is the original axis artery of the lower. To the right of the aorta, you can see the inferior vena cava. Remember, all blood vessels, without exceptions, are paired structures in the embryo. Inferior vena cava appears to be unpaired because of the right side. There was a corresponding developmental vessel on the left side also, which is called left internal left inferior vena cava. Left inferior vena cava, and this left, but the right vessel continues into the right atrium, which is on the right side. So the right inferior vena cava is under lower pressure. So all the blood from the left side is transferred to the right side because it's a lower pressure system, and all the vessels on the right side enter the left side via the vessel in the level of the kidney. So all vessels on the left side join the renal vein, and we said from the above superior mesenteric, from the below gonadal, they join the renal vein, and renal vein crosses over to the right side and joins the inferior vein. The right renal vein obviously is anyway close to the inferior vena cava. The length of the left renal vein and the right renal vein are unequal. So therefore, when you are giving live kidney donation, live kidney, that means live donor giving the kidney for their relatives or close relatives where they're suffering from bilateral kidney failure, you first assess the donor's kidney. If the donor's kidney are both functional and well functional, you prefer to give the left kidney because it is easier to operate with the left kidney because the left renal vein is quite long. The right renal vein is short, it can also be given, but you require a very skilled surgeon who will be able to make sure that the inferior vena cava is not damaged when you are removing the left kidney with a very short left renal vein. Another point to be noted, which we discussed in the previous class, that the left renal vein crosses in front of abdominal aorta, just below the opening of superior mesenteric artery. So superior mesenteric artery and the abdominal aorta compress the left renal vein sometimes, giving rise to what is called as nutcracker effect. And the suprarenal and gonadal arising, joining the renal vein before this nutcracker effect, can get a back pressure because of this nutcracker effect. One of the other reasons why varicocele is common on the left side. Another point to be noted is that the main renal artery on the right side passes behind the inferior vena cava. The suprarenal artery on the right side passes behind the inferior vena cava. The inferior phrenic artery on the right side going behind the inferior vena cava, but gonadal artery on the right side passes in front of inferior vena cava. 4 lateral branches, the inferior phrenic, the middle suprarenal, the renal, all 3 of the right side lateral branches pass behind IVC, whereas gonadal, which is also a lateral branch, passes in front of IVC. The reason for this is not the asymmetry of the lateral branches of aorta, it is the asymmetry of the development of the inferior vena cava. So what is the development of inferior vena cava? Remember, there are 3 sets of arteries which are present in the embryo. All 3 are paired. The vessel which drains the gut is called as vitelline vessels, right and left. The vitelline vessels give rise to part of portal vein. The umbilical vessels which drain from the placenta, right and left. Of course, the left vein is left behind. The right umbilical vein disappears in early embryonic life. All the blood is shunted to the left vein. And the third is called as cardinal system of veins. Draining the head region is called as anterior cardinal vein. Draining the lower part of the body region is called as posterior cardinal vein. The reason being, embryo's anatomical position is quadrupedal. So whatever is in front is called anterior. Whatever is behind is called posterior. Whatever is in the head side is called anterior. Whatever is in the tail side is called posterior. So the commencement of IVC is formed by the posterior cardinal vein. So this is where the 2 common iliacs join the IVC. So this part is called as the posterior cardinal. Then the portion where the gonadal vein crosses the IVC, that portion develops from supracardinal vein. Remember again, supra in embryo's anatomical position is more posterior. So gonadal vein passes in. The region where the kidney and the other lateral veins are developed is called as the subcardinal vein. Again, embryo's anatomical position, sub means more anterior. That's why the lateral arteries pass behind it. And in the region where the hepatic veins join, right hepatic, middle hepatic, and left hepatic veins join, that portion develops from the vitelline system. That portion is called as hepatocardiac chain. So this explains why the asymmetry of the lateral branches of abdominal aorta. Median sacral artery will have a median sacral vein. Median sacral vein is exactly in the midline. IVC is right in the midline. Therefore, median sacral vein joins the left common iliac vein, which is crossing the midline to reach the IVC on the right side. IVC develops at a vertebral level L5, just below the bifurcation of aorta, and it pierces the diaphragm at the vertebral level E8. Just as there are 4 lumbar branches from aorta, there are 4 lumbar veins draining the body wall, out of which only the 3rd and the 4th lumbar vein joins IVC. because that portion of the IVC is more posterior, supracardinal, closer to the body wall. Fourth and the third lumbar veins join the IVC. Whereas the first and the second lumbar vein do not find IVC there because IVC has come in more anterior plane, the subcardinal system. So there is a vessel on the posterior aspect, the supracardinal system, the posterior aspect, where the first and the second lumbar veins join. The first and the second lumbar veins on the right side joins the azygous vein. On the left side joins the hemiazygous vein. So these azygous and hemiazygous at the termination is a part of supracardinal system. That's why only two lumbar veins join the IVC, the third and the fourth, because that portion of IVC is supracardinal. The second and the first lumbar veins joins the azygous and hemiazygous, which is part of the supracardinal system of veins. Which is also why the azygous and the IVC join just below, just at the region of the renal veins. So that's the communication of inferior vena cava with superior vena cava, the azygous system of veins. So just as we discussed that when the superior vena cava is blocked, the azygous will show a backflow and flow into the IVC. If the inferior vena cava is blocked above the renal level, then the azygous will communicate IVC with SVC. Besides that, there are also the superficial thoracoepigastric vessels which are connecting axillary vein to femoral vein and vertebral venous plexus, which is communicating upper vessels and lower vessels in the vertebral column, all of which are valveless, and of course, superior epigastric vein and inferior epigastric vein show an anastomose with each other, and blood can flow in either direction depending on whether SVC is blocked or IVC is blocked. The SVC is blocked, all the blood will flow downwards in these systems and will join the IVC. If the IVC is blocked, all these vessels will drain upwards into the axillary, vertebral venous plexus, vertebral vein, the internal thoracic vein, all of which joins the SVC system. Left renal vein, we already said, longer vessel joined by superior mesenteric, not superior, joined by superior suprarenal and gonadal. Suprarenal and gonadal veins join the left side. It crosses the midline. And the fact that the vein crosses the midline in front of aorta implies that that portion of SVC is more anteriorly placed, and that is the subcardinal system of veins. Another question which is asked often is that kidney was developmentally in the pelvis, then it ascends up in the embryonic period, getting new vessels for it. Sometimes there are accessory renal vessels which either go near the inferior pole of the kidney or they go near the superior pole of the kidney. Accessory renal veins on the arteries on the right side, will it pass in front of IVC or behind the IVC? The answer is, just as we said, gonadal passes in front of IVC. Any accessory renal artery joining the lower pole will follow the course of gonadal and cross in front of IVC. Whereas any accessory renal artery which supplies the upper pole will follow the course of the renal artery and pass behind the IVC on the right side. Superior arteries, celiac trunk, superior mesenteric, inferior mesenteric have no corresponding tributaries of the inferior vena cava. All of them join the portal system of veins, which enters the liver, and then three hepatic veins replace the three GI tract branches of the abdomen. The next we focus is on the lymph nodes. The lymph nodes in relation to the posterior abdominal wall are named after the artery that it accompanies. So in the pelvis, there are internal iliac nodes. Along the margins of the pelvis, there is external iliac nodes, These are basic exercise like a very great continuation of inguinal group of nodes. And then there are lymph nodes in relation to the aorta. So those in front of aorta are called as pre-aortic nodes. Those on the sides of the aorta are called as para-aortic nodes. This pre-aortic nodes are subclassified into celiac nodes, the superior mesenteric nodes, and the inferior mesenteric nodes, draining finally from the foregut, abdomen, midgut, and hindgut. Pre-aortic and para-aortic. Both these aortic system of lymph nodes freely communicate with each other. Therefore, testicular cancer will initially go to para-aortic. The stomach cancer will initially go to pre-aortic. Because they communicate with each other, it doesn't really make a difference whether it joins the pre or para-aortic. Especially in case of cancer, where the normal channels are blocked, abnormal channels open up, and then the communication is even clearer. From the pre-aortic node, there is an intestinal lymph trunk, and from the para-aortic node, there is a lumbar lymph trunk. These join the cisterna chyli, which is lying on the posterior abdominal wall at the level of L1, L2 vertebra. From there, thoracic duct starts, which goes on the right side of the abdomen, enters through the aortic opening, crosses the midline behind the heart at the level of T5 vertebra, and then goes and joins the left venous angle. Here, some tributaries also join the thoracic duct in the neck region, and backflow of the cancer cells can cause a swelling in the left supraclavicular region, called as left supraclavicular lymph node enlargement, which was named after the scientist called Furco. Remember, V is to be pronounced as F and W is not to be pronounced. So it is called as Furco's lymph nodes. This is the representation of lumbar plexus. Lumbar plexus is defined as the network of nerves formed from the ventral rami of T12 to L4 nerves or anterior primary level. So T12 to L4 is the ventral rami, form a network which is called as lumbar plexus. Some people do not include T12, but there is often a communication between ventral rami of T12 and L4. This communication may be missing, in which case the lumbar plexus technically is strong only from T1 to T4. But T12 is to be included because often there is a communication between T12 and L1, which also becomes a part of the L1 nerve. Gives a branch called iliohypogastric nerve and gives a branch called ilioinguinal nerve. Hypogastric ilioinguinal. Just as every intercostal nerve has got the main trunk and has got a collateral branch. The ilioinguinal nerve is considered as a collateral branch of iliohypogastric nerve. The difference being in the intercostal space, the collateral nerve is only muscular, not cutaneous, whereas here ilioinguinal is very much cutaneous as well. It also supplies the lower part of the oblique muscles of the abdomen and the conjoint tendon. So very important, ilioinguinal, the motor part, which is responsible for prevention of direct inguinal harm. From L1 and L2 joints form the genitofemoral nerve. This should be correctly called as the femorogenital nerve, because the L1 component is femoral, which supplies skin of the inguinal region, just below the inguinal ligament, and the genital branch is L2, which supplies the cremaster muscle. So when we stimulate the skin of the thigh, medial part of the thigh, the L2 dermatome the genital branch will go into a reflex contraction, pulling up the testis, which is called as cremasteric reflex. So cremasteric reflex is the superficial reflex, but the spinal location is L2, simulating the skin on the medial side of the thigh causes a contraction of cremasteric. This reflex is prominently seen in small children, not seen in adults, because cremasteric is another hardly more of vestigial muscle. It is more of a cremasteric fascia rather than a muscle. Lateral cutaneous nerve of thigh supplies the skin on the lateral part of the thigh, and L2, 3, 4 posterior division forms a femoral nerve. It supplies the extensor muscles of the thigh, and anterior division of L2, 3, 4 forms the obturator nerve. L4 also gives rise to lumbosacral trunk along with L5. L4 nerve is therefore called as nervus furcalis because L4 nerve bifurcates, one joining the lumbar plexus and another joining the sacral plexus. You will notice obturator nerve and lumbosacral trunk are both passing medial to psoas major. Here we are seeing obturator nerve, skeletal nerve, and L4, L5 joining to form the sacral plexus. All the lateral branches, ilioepigasic, subcostal, ilioinguinal, lateral cutaneous nerve of thigh, and femoral, lie lateral to psoas major, whereas genitofemoral lies anterior to psoas. Just to recapitulate, ilioepigasic, ilioinguinal, lateral cutaneous nerve of thigh, and femoral nerve are all sequentially lateral to the psoas major. Another point to be remembered, the nerve which is going towards the anterior superior leg spine is a lateral cutaneous nerve of thigh. So identify that, and then you can calculate ilioinguinal, ilioepigasic, and subcostal. In front of psoas major is the genitofemoral. Medial to psoas major is obturator and lumbosacral trunk. The lateral cutaneous nerve of thigh, when it goes to the anterior superior leg spine, it pierces the inguinal ligament and then comes to the thigh region. So at times it may get trapped in the inguinal ligament, which is of course polyneuritic continuation of external oblique muscle. That will give rise to a tingling or numbness in the region of the lateral part of the thigh, which is called as neuralgia paresthetica. Lateral is not thigh going to the anterior superior leg spine, getting trapped in the inguinal ligament. The sacral plexus is more complex than the lumbar plexus because there are too many branches. So what we'll try to do is we'll try to remember the branches in a particular manner. The first branch is pudendal branch, pelvic flanking branch, and perineal branch of S4. Here you are seeing the pudendal nerve, the pelvic flanking nerve, and the perineal branch of S4 is supplying the pelvic diaphragm. All three nerves starting with letter P, all three nerves supplying pelvis. And of course, pudendal nerve continues to supply the lower part of the. The next three proximal branches are piriform nerve. The nerve to piriform is posterior femoral cutaneous nerve, which supplies the back of the eye, and perforating cutaneous nerve, which is the perforating cutaneous nerve, which also supplies part of the gluteal region. So 6 proximal branches: pudendal, pelvic flanking, perineal branch of S4, piriform, posterior femoral cutaneous, perforating cutaneous. 3 of which supply the pelvis, 3 of which supply the lower limb. The next 3 branches are branches from the anterior division, nerve to quadratus femoris, nerve to obturator internus. Obturator internus has got one muscle above it, one muscle below it. There are twin muscles called as gemellus superior, gemellus inferior. The nerve to obturator internus also supplies superior gemellus, because the nerve to quadratus femoris also supplies inferior geniculus. And tibial nerve formed from the ventral ray by ventral division, L4, L5, three branches from the posterior division, superior gluteal, supply gluteus medius minimus, flexor facial lateral, inferior gluteal, supply gluteus maximus, and common fibular nerve, formerly called common peroneal nerve, which will form from the dorsal divisions but ventral ray of L4, L5, S1, and S2. So remember the branches of sacral plexus. 6 proximal branches, all starting with letter P. 3 of them supply pelvis, 3 of them supply aorta. Distal branches are from either anterior division or posterior division. Now to quadratus femoris, now to observatory. Tibial, the ventral division. Superior gluteal, inferior gluteal, common fibular from the dorsal divisions. Remember, tibial nerve supplies the hamstrings and the posterior part of the thigh and the leg, both of which are ventral development of the lower limb, whereas the common fibular supplies the extensor muscles of the lower limb. Last slide is what we are discussing. There are autonomic nervous plexus in relation to the celiac trunk, which is called a celiac plexus. There are some ganglia associated with it. All these ganglia are sympathetic ganglia. There are plexus in the region of the superior mesenteric. There also have some ganglia. These ganglia are also of the sympathetic system. There are inferior mesenteric plexus along the inferior mesenteric artery. Point to be noted is that all these 3 plexus accompanies the artery to supply the abdominal part of foregut, midgut, and head. Besides these, there are 3 sets of plexus. Pelvis, the superior hypogastric plexus, inferior hypogastric plexus. Inferior hypogastric plexus are associated with ganglia, which are sympathetic again. Remember, parasympathetic ganglia lie in the wall of the organ that is supplied. The superior hypogastric plexus is located just below the bifurcation of the aorta. So technically it is in front of L5 vertebrae, not pelvic plexus. The inferior hypogastric plexus are the hypogastric plexus, which will lie on either side of the rectum. The vagus nerve passes through celiac plexus as a preganglionic fiber, which is myelinated, accompanies the celiac trunk and goes and supplies the abdominal part of foregut. The vagus nerve also gives a branch to the superior mesenteric plexus. Actually, the celiac plexus itself joins the superior mesenteric plexus. They accompany the superior mesenteric artery to reach the midgut structures. Inferior mesenteric plexus, the one which supplies hindgut, is not supplied by vagus. So left 1/3 of transverse colon, descending colon, sigmoid colon, rectum, anal canal have necessarily got to be supplied by the sacral nerves, the pelvic splanchnic. Pelvic splanchnic goes to the inferior hypogastric plexus without relaying both the supplies of pelvic organs. Few fibers from the superior hypogastric plexus, the inferior hypogastric plexus goes to the superior, and then from there to the inferior mesenteric, accompanies the inferior mesenteric artery and supplies the hindgut structures. The greater and lesser splanchnic nerves to the thoracic region relays in the pre-aortic ganglia, the celiac ganglia and the supramesenteric ganglia. Postganglionic fibers from these ganglia goes and supplies foregut midgut structures. Whereas inferior mesenteric plexus is branches from the lumbar part of the sympathetic chain. They are already relayed in the lumbar part of the sympathetic chain So the postganglionic fibers of the sympathetic system passes along with the inferior mesenteric plexus to go and supply the hindgut structures. Whereas there are some preganglionic branches through the superior hypoglossal plexus to the inferior hypoglossal plexus, relay the ganglia here and supply pelvic organs. Pelvic organs get the sympathetic supply in addition from the sacral splanchnic nerve. Sacral splanchnic nerve have relayed in the sacral part of the sympathetic chain. So only the postganglionic fibers which accompany mingles with the inferior hypoglossal plexus and goes and supplies the pelvic organ. So I'll repeat again. Vagus and pelvic splanchnic supply foregut, midgut by the vagus and hindgut and pelvic organs by pelvic splanchnic. Greater and lesser splanchnic from the thorax supply foregut, midgut. Greater splanchnic is C4 to T9. Lesser splanchnic is T9 to T11. There's also least splanchnic. Specifically, the lumbar splanchnic branches from the lumbar part of the sympathetic chain are pre and postganglionic. Both postganglionic mesenteric artery supply the hindgut. Preganglionic relays in the inferior hypoglossal ganglia, which is also mingled with the sacral splanchnics, which also are already postganglionic and relay from the postganglionic branches of the sympathetic goes and supplies the pelvic organs. So all the ganglia that were mentioned here are all parasympathetic, lying in the ormax, is the plexus of the body wall. With that, we come to the end of the discussion. You can mark your attendance in the chat box.